Okay, now in this section we're going to talk about the body's response to shock. We've already discussed the physiologic impact by different types of shock and bleeding on the body. Although we'll talk about the body's response to shock, it's important to know that our job is to help the body get through that shock state, because although the body does have mechanisms to compensate for low blood pressure, high blood pressure, some types of bleeding, when we're talking about major injuries, the body doesn't actually have enough time and doesn't create a powerful enough response to respond to the quickness of shock's onset. So the body has a number of compensation mechanisms that it can invoke to get through this process. And so we have the central nervous system's ischemic response, the hormonal mechanisms that are going to work in concert with the central nervous system. We have an adrenal medullary mechanism. The response of the renal system can include renin-angiotensin-aldosterone mechanism to help increase perfusion pressures. We can have an impact by antidiuretic hormone, and not necessarily important for our body's response to shock directly, but the opposite end of us having blood pressure issues would be too much blood volume, and so the body has the atrial natriuretic factor to deal with that as well. And so most of these things are all associated with our body's response to shock in low blood pressure, and then atrial natriuretic factor by itself kind of stands out as a means of dealing with blood pressure being too high. So just to get that out of the way, and then we'll carry on with low blood pressure discussion. Atrial natriuretic factor is going to respond when our body has too much volume and preload is too large, and it sends the signal from the atria. The cells in the atria, when they're stretched by that extra preload, are going to send a signal to the body, and that signal will eventually be read by the renal system. And the renal system is going to increase its release of salt and water in response so that the person urinates some of that pressure off. Now, again, not a major factor in patients that have low blood pressure, but the opposite mechanism. All these other mechanisms we're actually going to discuss as we move along. Okay, so once the body has a signal that it's been injured, and so let's kind of use the traditional pathway for this discussion, that the person's got a loss of blood. When blood vessels are damaged, what generally occurs is releasing of certain chemicals by the cells that were damaged, and then by our sentinel cells that are within our bloodstream kind of on standby. And so once the person has an injury to a blood vessel and bleeding has occurred, the patient's going to start activating, in a healthy normal patient, start activating their coagulation cascade. The coagulation cascade is pretty complex, and there's about 13 factors that we've identified that lead to the response of having an actual clot being built. Now, it's important to know that when the coagulation cascade is activated, at the same time as we have the coagulation occurring, the body's also releasing chemicals that are going to start breaking down clots at the same time. And so this is a protective mechanism to kind of manage against excessive clot building. Is if the person has clot circulating through their bloodstream, obviously that's a bad thing because it can cause occlusion throughout the entire body. So when we administer IV fluids to patients, and generally we're administering things like lactated ringers or normal saline as opposed to blood. When we give just crystalloid solutions, we actually dilute the blood. And so we may increase perfusion pressure, but we're at the same time kind of losing a couple of aspects of it. If they've been bleeding, they've lost red blood cells, and crystalloid solution, as we'll talk about a few times, does not replace the hemoglobin carrying capability. It just takes the cells that are there still and makes the perfusion pressure higher so that they can go by and deliver their oxygen and get rid of CO2 probably at a more frequent rate once they have more perfusion or volume in their stream. And so if they do that, they also, when we give those folks crystalloid solution, they also lose the clotting cascade, right? If they're bleeding out, they're going to bleed out whole blood. And in bleeding out whole blood, they're going to lose all these clotting factors that eventually would come together and respond, and we dilute it. And so some of them will be too far apart. We won't have enough in a local area to respond. And so that can pose a problem for our patients, and that'll come up as part of our treatment, a concern that we have for treatment. So in order to manage those fluids, our body has some natural processes that are going to occur. And some of this is just essentially following the laws of diffusion gradients, right? Moving from areas of higher concentration to lower concentration, as long as we have a mechanism or a membrane that can do that. And so that's what we're going to talk about now, is kind of moving through the different spaces in our bloodstream. So the movement of fluid is going to occur in a few different areas, and this is relevant because this process happens before we get there often and is happening while we're there, but our fluids are going to be impacted by these laws. And so fluid movement is going to kind of happen within three different major processes. One is fluid moving through the vasculature, and we've already kind of talked about that using cardiac output and mean arterial pressure as a measurement. Things like preload and afterload are going to come into account, and the body responds to shock differently at different ages as well. Now, the fluid needs to eventually get from its entry point, wherever we start our IV, into the bloodstream, and then hopefully at some point it will start to rehydrate cells that were dehydrated. So we have movement across capillaries and movement across membranes. So movement across capillaries is essentially what happens when fluid is leaving the vasculature at the capillary level and going into the interstitial fluid. That interstitial fluid is the fluid that's surrounding our cells. It's the fluid that our cells are bathed in. Once we have things that are crossing that capillary, it's generally one cell thickness for the capillary, then it's going to travel through, and in order to get into the intracellular space, it has to travel through the cell's membrane. So from interstitial space to intracellular compartments is our movement across membranes. So those three things are occurring, and they'll work in multiple directions depending on the concentration of fluids that are within them. The things that are kind of influencing and impacting that fluid movement are going to include things like hydrostatic pressure, oncotic pressure gradients, and capillary permeability. So capillary permeability we probably heard before. This is associated with leaky capillaries in some cases. But remember that capillaries are designed so that certain things will move through easier than others. And so that permeability speaks not just to leaky capillaries when there's an injury, but the natural movement of things across this capillary cell wall. Now, the hydrostatic and oncotic pressures are kind of working in concert and sometimes oppose each other. So hydrostatic pressure is going to be the pressure that's inside the capillary with the volume of fluid that's pushing outward against the capillary walls. There's also hydrostatic pressure pushing inward from the interstitial space. So the membrane around the capillary has hydrostatic pressure pushing against it from both directions. Now, that pressure is partly going to be associated with volume. So if there's higher volume inside the capillary than there is inside the interstitial space, that creates a gradient. Oncotic pressure is a little bit different. So oncotic pressure is going to be the pressure that's coming up because of the tonicity or the stuff that's inside of fluid. So oncotic pressure is that rule that water is generally going to go to an area where there's more stuff in it to kind of dilute and find some type of equilibrium between the two sides. And so if we just kind of draw a really simple diagram here, and we say right down the center we have a semi-permeable membrane, and let's say it's only permeable to water, so only water can get through. If our solution starts off at one level on both sides, but one side has more stuff in it, so we'll say one side's got 6 things in it, and the other has 3, what's going to happen is we have actually more water on side A than we do on side B. Water's movement is going to go from an area of low concentration of stuff, okay, so that's side A, to the higher concentration, trying to kind of thin out, if you will, that solution. So what ends up happening afterwards is if water volume leaves one side and stays there, then one side's going to actually increase its volume, and the other side will decrease its volume. And so that's the oncotic pressure, driven by the tonicity, or how much of these things are inside the fluid. Now, if we have volume loss, and let's say that the patient's not bleeding, but inside the bloodstream they've lost plasma because of, say, dehydration or maybe major burns, when that occurs, they leave the red blood cells and the formed elements in place, and the plasma, the water stuff, generally leaves. And so if we lose water out of the bloodstream is going to become thicker and a little bit harder for us to kind of move that sludge around. Okay, so in this slide, we've got a picture of a capillary circulating through, and we've got intravenous space inside the vessel, interstitial space outside the vessel, and then let's just draw a cell over here, and so we have intracellular space as well. In green, I'm going to draw our hydrostatic pressure. So the hydrostatic pressure is pushing against the wall of the capillary, both from within the capillary or intravenous space and from outside the capillary or interstitial space. If the pressure gradient goes down, hydrostatic pressure gradient goes down on one side, then water will be drawn in from the other side to try and reach balance. in blue here, I'll draw our oncotic pressure difference. So the oncotic pressure is going to depend on how much stuff is present. So if our interstitial space, again, has, let's say, 6 things floating around inside of it, and the intravenous space has, play along with me on this one, if the intravenous space has 3 things in it and the interstitial space has 5 things in it, then there's more fluid, more water in the intravenous space. So the oncotic gradient will draw water into the area that has higher concentration of stuff to help dilute it and thin that out. Now, if the intercellular space has 3 things in it compared to interstitial space, then the intercellular space might need water drawn in from the interstitial. So when we give IV fluids, those fluids, depending on which tonicity, hyperisotonic or hypotonic, those fluids are generally going to leave the blood vessels. Okay, so now we've seen those different directions. Now, let's say that the patient's got a broken blood vessel, right? So we'll say the break is here, and they're losing red blood cells out of the body. So when that occurs, they're going to lose whole blood, and so the hydrostatic pressure inside the blood vessel will go down. And that's because there's less volume, right? So there's less pressure associated with it. Now, as the hydrostatic pressure goes down, we probably, at the same time in the interstitial space, we're sensing that. And so as the hydrostatic pressure goes down, fluid will leave the interstitial space to try and fill the volume of the capillary. The cell that's in this space as well, eventually, as the interstitial space loses volume, the cell will start to send fluid across its membrane. And so that fluid will go to the interstitial space temporarily and then eventually go on to leave and go into the intravascular space. So in shock, patients' cells at interstitial space are generally dehydrated because of the normal movement of fluids in that situation. And this kind of lays out the idea that if we give patients isotonic solutions, eventually that fluid is going to leave the blood vessel and go into the interstitial space and intracellular space, which means that our blood pressure might go down and we can't rely on fluids to stay in for a very long time. Now, our body is sensing this all day long, and so some of this is just a normal response. It's happening in small amounts when the body senses that it's dehydrated. We could be dehydrated many points in a day. Say we drink lots of water in the morning, we get to our job, and we're fighting a fire, we get out of that, we're probably dehydrated at that point as well. And so our body's doing these things to try and maintain a normal blood pressure despite the loss of fluid when we sweat and urinate and a lack of or a gain of fluid when we ingest it. So our body's sensing this partly by 2 big mechanisms. One is the baroreceptors. The baroreceptors, baro meaning pressure, are measuring the blood pressure within circulation, both inside the carotid bodies and the aortic arch. The signal that pressure has gone down will be sensed and sent back to the brainstem's medullary vital center via, for the carotid bodies, the 9th cranial nerve, and for the aortic arch, the 10th cranial nerve. Now, the body senses this inside the brainstem and then makes some changes through our major vasocenter. And so those communications will result in blood pressure going up or going down, or rather a heart rate going up and going down based on our cardiac output formula. Remembering that cardiac output equals stroke volume times heart rate. If the stroke volume goes down, we can compensate by increasing heart rate. And so the fibers that I've drawn here, yellow is going to be our parasympathetic fiber, and sympathetic fibers will be in green. So we have both parasympathetic and sympathetic fibers going to the heart, and that's going to have an impact on the SA node, and so it can change things like our rate and our force of contraction. The sympathetic fibers, if we're having to respond to this change in blood pressure, the sympathetic fibers are going to cause things like vasoconstriction to occur. And I'm showing here that the parasympathetic fibers branch off in the cervical spine, and the sympathetic fibers branch off in the thorax, back to our thoracolumbar versus cranial sacral descriptions of sympathetic and parasympathetic fibers. So those are the major changes that can occur within the cardiovascular system, but there's even more that the body's going to be doing. At the same time this is occurring, we may send a signal that causes the adrenal glands to send off things like epinephrine and norepinephrine. Those hormones will circulate through the body and have more effect on blood vessels and other organs. also, the glomerular filtration rate is going to go down and be sensed inside the kidneys. So at the JG cells surrounding the glomerulus of our kidneys, where our nephron is, if filtration goes down, then our body's response is to invoke the renin-angiotensin-aldosterone system. So let's look at those steps just really quickly. And so one of the first things that occurs is the release from the JG cells of renin. And renin by itself doesn't do a whole lot for this process. At the same time, the liver is releasing a chemical called angiotensinogen. I'm just going to put it as here's angiotensinogen. Angiotensinogen doesn't do a whole lot by itself. But these two things will link up, renin and angiotensinogen, and create angiotensin 1. Angiotensin 1 is actually not very responsive either, but through a process occurring inside the lungs, angiotensin converting enzyme will convert angiotensin 1 to angiotensin 2. And angiotensin 2 then does have an effect on our body. Angiotensin 2 can do a few things. It can change our blood vessel diameter. It can have a sympathetic kick, so our blood vessels will constrict, and that might increase our patient's preload, hopefully. So increased sympathetic response. Also, angiotensin 2 will stimulate the release of aldosterone. Aldosterone is a chemical in the body, a hormone that can change the way that our kidneys retain sodium, and so that helps change the way that our kidneys retain water. So if we increase sodium and H2O retention, then we're not urinating as much fluid off, and so our blood pressure shouldn't go down from the urination mechanism. It's a means of trying to hold on to whatever pressure we have at that time. Also, coming out of the pituitary gland, the patient can have antidiuretic hormone, and antidiuretic hormone's release will eventually impact the kidneys and give a further signal to try and hold on to that fluid. So the kidneys can have multiple mechanisms telling it to suppress its filtration, and in doing so, we at least don't have multiple means of losing fluid, one from bleeding and one from urinating off. So that's the baroreceptor response really in total. So renin-angiotensin aldosterone system will be involved, the sympathetic nervous system will be involved, increasing heart rate, force of contraction, and causing vasoconstriction throughout the body. And you can see that these things kind of feed each other. The signal that was sent from the brain down into the adrenal gland will release epinephrine, norepinephrine. Renin being released after a decrease in glomerular filtration rate will eventually release angiotensin 2, and angiotensin 2 increases sympathetic response even further. So we have multiple mechanisms here to help that patient get through it. Okay, so let's talk about chemoreceptors. Chemo are the other type of receptor from baroreceptor that are going to be involved in this process. Chemoreceptors, chemo for chemical, are going to be measuring things like a decrease in oxygen, a increase in acid, which would be a decrease in pH, and an increase in CO2. So it's measuring these things actually in similar locations to the baroreceptors. We do have the aortic arch, carotid bodies, but then it's also measuring this in cerebral spinal fluid as well. So we can have central measurement and peripheral measurement of our chemoreceptors. So they're measuring the sensitivity and change, and when they respond and communicate with the brainstem, the chemoreceptors can cause changes in the pons and the medulla. So the reason for that is our mechanism for breathing is spread across the pons and the medulla as well. So when we're breathing, remember that the normal patient is breathing primarily because of increases in CO2 to get rid of that amount of CO2 by increasing their ventilatory rate and depth, and not necessarily for oxygen. Our body doesn't breathe because it needs oxygen unless we're in a state like our COPD patients who are always using their hypoxic drive. So as the patient has an increase in CO2, decrease in O2, or an increase in acid, it's going to invoke, after the first buffer system of the blood has been completely utilized, then it causes stimulation for the ventilatory rate to increase. The ventilatory rate increase is also going to come with some changes that can occur. The ventilatory rate increase is going to also be coupled with sympathetic and parasympathetic responses as well. So not only will the body's vasocenter become active, but our ventilatory rate and our respiratory center will become active as a buffer system. So as we experience states of low oxygen or higher CO2, our ventilatory rate should increase. And the more that we see that increase in CO2 or decrease in oxygen, the more the ventilatory rate increases. So remember that our first sign of shock is essentially a high normal ventilatory rate, especially in class 1 hemorrhagic shock. And we also can have a change in the patient's mentation. So those two things are the earliest signs that the patient is experiencing hypoperfusion. And it should make sense, right? Because in early hypoperfusion, we don't have yet massive shifts of blood pressure. We have smaller shifts of blood pressure, and the body's trying to compensate through our baroreceptors response. And then we're also sensing that there's a change in the oxygen and CO2 concentrations. So the ventilatory rate will generally go up before any other vital sign is going to be impacted because of the accumulation of acid. Now, our body generally will respond in a predictable way to the process of losing blood volume. And so it doesn't really matter which way we're losing blood volume. The stages here are basically showing our stage to death. And so the body will go through a stepwise process, and that rate that they go through each step is going to be different, obviously, for every patient based on their condition and based on the type of shock that they're experiencing. And so we'll just talk about each of these stages because it kind of helps define for us why certain things are occurring in the body in a predictable order. I'm going to draw for us a blood vessel here. And so our blood vessel is delivering to this area here that we'll say is our capillary. And the flow of blood is going to be this way from left to right. So that would mean that our left side blood vessel is arterial and the right side vessel is venous. So inside we have the capillary. Remember, the capillary is made up of cells that are lining this vessel. And the cells should generally have a tight enough connection that things don't easily leak out, right? So that's kind of our starting point. When the patient goes through changes like decreases in blood pressure, what ends up happening is the body can respond not by kind of collapsing and constricting the capillary, because remember, the capillary has one cell thickness to it. It doesn't have muscle cells associated with the lining of the capillary, but it does have muscle cells associated with the sphincters. So these sphincters are bands of smooth muscle, and so we have a precapillary sphincter and a postcapillary sphincter. So the precapillary, obviously before the capillary, so that's going to be the arterial side, and the postcapillary on the venous side. So the first stage is the body going through a state of profound vasoconstriction. So this occurs where vasoconstriction is going to cause blood vessels throughout the entire body, especially in the periphery, to get as small as possible. And our goal is to shunt blood away from the extremities and towards the core, where our organs can't do well with ischemia for very long. And so that shunting is partly from vasoconstriction, but that isn't by itself enough. At the same time we have vasoconstriction, what ends up happening is the pre- and post-capillary sphincters are going to activate and shut down the capillary. So that causes blood that's inside the capillary to stay there and become stagnant. Remember also that these are muscle. So when muscle is doing work, it's consuming oxygen and creating waste, and at least CO2 being part of that waste. So they're constricted, meaning that they are consuming oxygen at a faster rate than if they were relaxed. And so as they do so, remember, there's no blood supply that's coming to either side, so it can only use the oxygen that it has nearby. After that's used up, it can go into anaerobic metabolism, but will create much more CO2 and a lot of acid waste. So as that acid and CO2 builds up, it eventually has an impact on the cells. So the buildup is also going to cause clotting to occur inside the stagnant tissue or inside the stagnant blood that's been left behind when the body shunted this blood away. And so as this starts to occur, the clotting mechanisms are going to be consumed, which means that they may not be available to respond to bleeding later. Now, as the body progresses through, the vasoconstriction and the capillary sphincters closing off to shunt blood back to the core is what gives us our compensated shock. So as long as that's intact, our body may be able to survive by compensating and increasing the blood pressure through things like changing our heart rate and changing the stroke volume that returns by shunting blood back to the core. But eventually this is going to fail. And so eventually what happens is capillary and venule opening. Let's start with the fresh drawing here. So I'll change, I'll draw our capillary again here. Again, blood flow from left to right, arterial side, venous side. And as the patient experiences a long-term set of shock, so these cells have been forced to constrict over a period of time, let's say that our postcapillary sphincter is closed, one of the first things that happens is our precapillary sphincter opens. It's not supposed to open, but it does so because, unfortunately, it is trying to do all of this work without delivery of oxygen and without evacuating waste. So eventually that's going to cause these muscle cells to fail. When that occurs, we end up with fluid rushing in that was remaining in the arterial blood supply. Fluid rushes into the space, and now we have mixing of the fluid that was stagnant inside the capillary, and all the clots and all the waste. pH is high, pH is low rather. Acid is high here. CO2 is high here. Oxygen is low. All those things are starting to cause these cells to die. And so as the cells die in the intracellular space, in the interstitial space, they're going to release things like lysosomes. So little digestive bags that will digest other cells that are in the process of dying but not necessarily dead yet. Will release tons of CO2 and acid. So all of these things are now mixing with the clots that are forming inside the capillary. Eventually, though, the next step is the postcapillary sphincter will relax and we'll end up with a period of washout. The washout phase is now bringing all of these capillaries open and sending the stuff that was sitting in the capillary and the new blood that's being supplied from the arterial side, mixing together, it sends it through to the venous side. And this happens throughout the entire body. So if all of our muscles that are allowing us to compensate for shock are starting to fail, then we're probably entering our decompensated shock phase. Once this occurs, we have a process that is going to reliably occur in patients in the later stages of their shock. So after the capillaries open up and the washout phase draws fluid back into the bloodstream that has a combination of clotting mechanisms being activated and being consumed, and the body trying to break those things down now that blood is returning to that region, we end up with a systemic process of blood simultaneously clotting and creating the factors that destroy the clots. And so what's ending up occurring as a result of this is an increase in microemboli. That process is called DIC, or Disseminated Intravascular Coagulopathy. So in this process, the coagulation that's occurring is going to consume the clotting factors. That means they're not available to do things like respond to the other areas of bleeding in the body. These microemboli are going to start lodging inside organ capillaries, and that will lead to organs starting to fail and shut down. And so one of the sensitive areas to this is going to be the kidneys. So kidneys can go through a period of hypoxia pretty early because of the emboli that's occurring. After all of this continues on, then the patient's going to go through a phase of being quite acidotic because they've released all that acid into the bloodstream, and their body, even in the core, is going to try to compensate for it. That washout phase leading to DIC eventually will lead to multiple organ failure. Multiple organ failure is essentially the failure of organs in different systems. And as this occurs, it basically lays out the patient going into a state of irreversible shock. Now, we'll still work our hardest, but it may be that the body is starting to shut down so quickly that our efforts are not going to be, well, not just our efforts, but our efforts and potentially definitive care's efforts won't be fruitful in trying to manage this. So as a process, this will cause the blood pressure and MAP to fall dramatically. Patients will start to shut down their liver, kidney, and then eventually the heart, lungs, and brain. And so this is the precursor to our patients going into cardiac arrest. Now remember that the decreased level of consciousness, even though it's a slight one with just anxiety showing in the early phases, is one of the first signs that we'll have a shock with our change in ventilatory rate. And so a few things can happen. We can have decreased cerebral perfusion as a result, and that will generally lead to increased hypoxia, and their LOC will probably start to fall dramatically at that point. So again, going into our process of decompensated shock, once that failure occurs, most organs in the body can't keep up. The brain is no different from it. Now, they could be having other things associated that are causing an LOC change in their presence of shock and trauma. Maybe that's a medical cause of their their injury. Maybe they had a change in their blood pressure, maybe a change in their blood sugar, and so they're not able to think correctly, and then they get in a car accident and suffer injuries. Now, it's difficult, though, because we kind of have to weigh which thing is killing the patient quickest. If the patient is in decompensated shock, it's very likely that shock's going to be the thing that kills them first. And so we don't want to go off on tangents and try to manage other parts of the patient's issue if we haven't managed their core survival function of maintaining adequate perfusion. So try and weigh that, but it's likely that shock is going to kill this patient faster than any other cause. Patients will be tachypnic, remember, because of a change in their blood pH. So their CO2 values are going to go up. That means their pH value goes down, and so they're blowing that off. And so remember that patients, when they are without oxygen and when they're quite acidotic, their thinking doesn't do well, right? So as their LOC changes, patients might be intolerant of oxygen masks or BVM or just non-rebreather in general because of that claustrophobic feeling it gives them. This is just their brain shutting down, unfortunately. It's nothing personal against you. It means that their higher level of thought processes are starting to fail because of a lack of perfusion, a lack of oxygen to do its work, and so the body reverts to our very animal function, our basic animal vegetative functions, in which we can only perceive things like threat or not threat. And so if we're coming at the patient and they don't know what's going on because their brain can't think very well and they're in shock, if we try to put something on their face, that could be seen as a sign of aggression, so the patient might aggressively try to fight back. It's just the oxygenation really showing you how severe their cerebral perfusion is. Okay, so compensated shock versus decompensated shock is essentially talking about the difference in the patient's blood pressure, right? So if the patient's blood pressure starts to fall, that means that we're in decompensated shock. Decompensated shock, when it goes on for quite a while, unfortunately, can lead to something like irreversible shock. If we're talking about shock from hemorrhaging, remember that class 1 and 2 shock is the compensated shock, and class 3 and 4 are decompensated shock, because that's the separation of our blood pressure being normal and compensating and our blood pressure starting to fall. Let's talk about some special considerations for certain patient populations and their body's ability to respond to shock. Athletes are at risk of being misidentified, and part of that is because if a patient is an endurance athlete, their body's already gotten used to dealing with anaerobic metabolism, and so that's what their training was, to put their body into anaerobic metabolism and see that it could do more with less oxygen. So if these patients have resting heart rates that's well below our normal range, so below 60 beats per minute, that may be normal for them, and in other cases it's probably fine. But if their heart rate is that low, a few things might occur. One, their heart rate, when it increases, might not increase volume quick enough, rather our cardiac output quick enough. And also, we might misidentify a patient who would be tachycardic if their heart rate was within the normal range to start with, but their heart rate increasing to compensate may not go above the tachycardic level until well into their shock state. So we want to be on guard that these patients might actually show signs of shock a little later and might be harder to manage because of it. Geriatric patients have a few things going on. One of them is that their blood vessels probably don't respond as well through vasoconstriction to the body's request, because in the patient's just normal process of becoming a geriatric patient, even if they were healthy otherwise, they're going to have some level of arteriosclerosis that's going to limit the ability of the blood vessels to dilate and constrict. So the body's response to shock might be inhibited in that phase. Their stretch and rebound effect of contractility might not be as effective either. So cardiac output might be at severe risk of falling early in these patients. They might also be on medications, but in general, medications might inhibit the body's response to shock. So we've talked about a couple of them. So one of them being our beta blockers. For example, beta blockers, if they're given, are going to inhibit the body's response of the sympathetic nervous system to increase the patient's heart rate. And so that could come with a coupled decrease in the patient's inotropic or force of contraction. And both of those things together may mean that the body can't compensate at all. So when the body is sending a signal, increase heart rate so that we can increase cardiac output, it will send the signal, but the heart won't receive it because of the beta blocking effect. Pacemakers, kind of similarly, can cause issues. A pacemaker might not allow the heart rate to go up when the patient's got a need for a change in their cardiac output. So very much like our beta blockers, this could be an impedance in the patient's response as well. Pediatric patients. What do we know about pediatric patients and the compensation for shock or things in general? Well, we know that they compensate really, really well. And so they compensate so well that it could look like they don't have much of a problem. It might lessen your suspicion for a severe injury. But the problem is that these patients can vasoconstrict well, they can change their heart rate well, but they don't have energy reserves to do it for very long. So patients that are pediatric compensating for shock will compensate, and then just suddenly fall. And at that point, they fall very quickly. And so we really want to make sure we try to find our patients in the condition or find shock in our patients when they're in that compensation and recognize it for what it is so that we can work ahead of the game before their pressure falls. Pregnancy patients, there's a couple concerns here. One of them is that in patients in their second and third trimester will generally have more blood volume, in some cases up to 50% more blood volume. Some of the risks that can occur is because the patient has more volume, it could seem as though they lose some but compensate really well for it. Well, the body compensates, that's sure, that happens, but it does so by shutting off blood supply to baby as well. So before we see external signs of shock in mom, the child might already be going through a state of hypoperfusion. And so also their blood pressure might be slightly elevated, which makes us think that their blood pressure, when we find them, still may be normal in the general scheme of 120/80, but not normal for that patient. And so it can skew our views to shock and make it so that we don't find shock until much later in the process in a pregnant patient. So, but remember, we save the baby by resuscitating and saving mom. Okay, so remember we have different shock types, right? So we have hypovolemic, and hypovolemic is the most common type of shock that's present in trauma patients. In fact, if a patient has signs of shock and we don't have external bleeding or other mechanisms to blame, then we're going to consider this being hypovolemic shock until proven otherwise. Hypovolemic shock also has within it hemorrhagic shock, including external and internal bleeding. Distributive shock might also be termed in trauma vasogenic, as opposed to distributive shock from medical causes. And then cardiogenic shock we can discuss by breaking down into a few different subtypes. So let's talk about what's happening when each type of shock is present. In distributive shock, especially when we're talking about vasogenic shock from causes like neurogenic or spinal cord injury, patients are going to have massive vasodilation below the point of injury. Also, though, because we have distributive shock in general listed here, things like anaphylaxis and sepsis will become a concern. Major responses from the body to fight an infection, for example, in sepsis, or maybe major responses in the body to fight an invader in anaphylaxis, can lead to things like vasodilation and leaky capillaries. So blood can leave the blood vessels, not leaving the body, and go into places like our interstitial space. That means blood volume still goes down in the process. Neurogenic shock by itself is an excellent example of a unique type of shock in trauma. And so with neurogenic shock, as mentioned, we lose that tone because of a loss of communication from the bloodstream, from the nervous system, and that causes vasodilation. So we get relative hypovolemia, meaning that they don't really lose volume, it's just put in a different location in their body. So the unopposed parasympathetic activity can occur if the supply of the sympathetic nervous system has been cut, and only the parasympathetic nervous system is now communicating with the heart. So we can have patients that end up bradycardic because of this. So in patients that have neurogenic shock, we can have a number of things contributing to their hypotension. They could have a low heart rate, so that's not compensating for cardiac output. Their stroke volume can go down because now it's being put to the other parts of the body, and vasoconstriction isn't going to increase preload. And they have a decrease in the resistance because all blood vessels have dilated, and so now all things, afterload and preload, will start to fall, and so we have profound changes in blood pressure. So important to note that the bradycardia just kind of depends on where their injury is. They may have tachycardia and still be in neurogenic shock depending on the level of their spinal cord injury. Septic shock has, and just briefly discussing it since we're talking about all shock in general here, septic shock is a very complex process, and so it depends on what type of illness they have going into the septic shock as to some of the major questions about their presentation. So I encourage you to read as much as you can about septic shock, and we're changing our response to septic shock in EMS as we go. So generally this can result not just from the infection, but because of the chemicals that are released both by the invading material and our body in responding to the infection. So the two major things that occur are vasodilation and leaky capillaries, causing blood flow to go into different regions of the body and fluid to leave the capillaries. So signs and symptoms can include a fever, and now that fever might be low or high-grade fever depending on where they are in their septic process. So don't expect that they'll always be really, really warm in the presence. In fact, as they go through later stages of shock, they actually become cool and clammy based on the massive vasoconstriction that's going to occur and their hypotension. So tachycardia and hypotension might be late signs in the presentation of a patient with sepsis. Cardiogenic shock is shock involving the pump, right? So the circulatory function of the heart being damaged. And so there's a few ways that this can occur. We categorize these into intrinsic and extrinsic causes. So on this slide, we've got our intrinsic causes listed. We also have obstructive, but we'll talk about that with our extrinsic causes. So intrinsic causes are going to be problems within the heart itself that are decreasing its ability to create a strong pulse wave and send that through the bloodstream to create a blood pressure. So intrinsic causes can occur from medical causes and traumatic causes that lead to heart muscle damage. And so think about a patient that's in a severe heart attack. Their blood pressure might go down because of cardiogenic shock. Dysrhythmias can cause this as well by affecting both heart rate and stroke volume in some cases, or one or the other. And then valvular disruption actually makes it so that when the ventricle squeezes, blood becomes leaky. It leaks through the incompetent valve, and so doesn't hold its pressure within that chamber before sending it through the artery that it's entering into. And so as blood leaks back into the other chamber, the patient experiences both blood pressure falling because of the change of stroke volume, but some of that blood might mix together and they have a potential of generating clots. The cardiogenic extrinsic shock can also be termed, in PHTLS they do use this term, obstructive shock. And so it's basically an obstruction making it so that the heart can't have an increased stroke volume. So part of that could come from increased pressure on the outside of the heart. That can occur from things like the increased pressure on the mediastinum from a tension pneumothorax, or pericardial fluid occurring in pericardial tamponade, in which it occurs inside the pericardial sac. The sac itself doesn't stretch because it's fibrous, but heart muscle is pliable. So the pressure that develops in that sac will put pressure inward onto the heart, and that makes it so the ventricle can't expand to increase the volume before it contracts and sends fluid forward. So in these cases, the stroke volume is going to go down dramatically, and we need to fix the cause in order to fix the cardiogenic shock. Just a reminder that we do have some changes in PHTLS's primary assessment, and we haven't discussed this part yet, but there's also a assessment called the March assessment. This is pretty big in the tactical environment, so I just kind of wanted to give you a overview of these two types of assessment. They actually cross over quite well, and so if you're using one, you generally are taking care of the same issues of the other. So normally our X, A, B, C, D, and E, reminder that we're using the X to remind us that we must treat exsanguination first and foremost, before problems with A, B, C, D, and E. And so it means we have to assess it as well. The March assessment is going to be assessing for massive bleeding in the first step. So M is for massive bleeding, and that relates to our exsanguination assessment. If they have massive bleeding, the March assessment also has you memorize treatment for it. So massive bleeding needs to be managed with a tourniquet or with a pressure dressing. And that bleeding has to be managed first and foremost. The A is for airway and March assessment, so it's a reminder that we need to manage patients' airway obstruction. We need to do so early, but only if we can do so after managing their bleeding. Respirations here in the March assessment is a reminder that we need to manage things that are impacting their ventilatory rate and their respiration process. And so we might have to do things like a needle thoracentesis using a dart to decompress the lungs if that is present in trauma. We would find that by changes in their ventilations and by assessing their mechanism with lung sounds as well. Circulation here is not a reminder about their bleeding, but it's a reminder to check for presence of shock. And so that's through changes in heart rate. Eventually, when we're in our secondary, we'll check for blood pressure. And because of this, we need to make sure that we're warming our patient and actively treating against our hypothermia. The H is for a reminder for head injuries and hypothermia. We might find mental disability with that, and hypothermia might go with our exposure in the XABCDE model. If the patient has a head injury, we also want to suspect cervical spine injuries and assess for that. So it's a reminder to hold C-spine when required. So in this process, remember that hypothermia comes on because patients have a decrease in shock. They have a decreased rate of metabolism of creating that energy because of anaerobic metabolism, and so that decreases the amount of heat that they're producing as well. And that brings us to the end of our body's response to shock. Now, the next discussion we'll use is to discuss how we respond and help the body respond to shock in different states.